Welcome to the Rehab Science Podcast, everyone. I am your host, Dr. Tom Walter. Super excited about today's episode. We are going to be talking to Dr. Wesley Wang, a fellow physical therapist who specializes in ACL rehab. So this is an area I was telling Wesley before we got on, super excited to just kind of hear the current state of where we're at with just ACL injuries and rehab. I spent the first couple of years out of school was in a clinic where I did see a fair number of ACL patients, but I've been out 17 years, so it's been a while since I've treated a lot of people who have had this injury. So I think this will be a super helpful episode if you're someone who maybe has had an ACL injury and just kind of wanted to learn more about it, or you're a practitioner who treats these types of patients once in a while. So Wesley, thanks for coming on, man.
Appreciate you having me, Tom. I'm excited about this podcast.
Heck yeah. So can you give us a kind of a little background on how long have you been out as a PT and what made you decide to go down this road of specializing in ACL rehab?
Sure. So I graduated from Franklin PH University in 2015, so I'm just over 9 years now. I sort of worked at more traditional outpatient facilities for about 2 years, and then thankfully Teddy brought me over to Healthy Baller, which is a cash-based facility, about 7 years ago now. I just hit my 7-year anniversary. And, when you are in this setting, it's sort of nice to be known for something. And, he sort of would just ask me questions about, what do you want to like specialize in and what really you're passionate about. And ultimately I landed on ACLs because I've been through it myself twice. And it sort of was just, it was very natural. And at that time when him and I had that conversation, I had my first ACL patient here at Healthy Baller. And, we got really close, and she was she was a high school at that time, but became a college athlete, playing soccer, and just sort of like seeing that process and helping her. Her leg was a stick when she first came to see me, and then building her back. And she was like, I feel really, really strong going to college. And it was just a really fun experience to be a part of. And then also just reevaluating why I pursued the field in the first place, which is ultimately because I tore my own ACL going through the rehab process, really fell in love with the process of just like essentially getting better each week and going from, crutches, brace, blood, all that stuff to all the way back to playing sports again is a really fun journey to be a part of. And that's ultimately what I landed on. And I was a second PT hired here, and we're up to 9 therapists now. And we're
Wow.
fortunate enough to sort of develop a pretty good name for ourselves in ACL rehab. And all of us, all 9 of us have ACL patients on our caseload. So it's been a really sort of a fun process on both myself as a practitioner, but also on the business side of developing, a recognition for being a good facility for ACL rehab.
That's so cool. So I didn't realize Healthy Baller is all cash based.
Yep. Yep.
Wow. And is it all, I mean, like the name says, it's all pretty much athletes, sort of like sports medicine?
Yeah, I would say like 90 to 95% of my patients are high school and college level athletes. I do get the occasional pro. Like right now, I have a pro soccer player right now, and I just graduated one over the summertime. So I do get the occasional pro athlete, but high school and college level athletes make up the majority of our caseload. And we do see a good amount of active adults. People who want to get back to playing, adult leagues or want to hike, ski, all that kind of stuff. So we see a lot of those as well.
How are your guys' sessions structured? Is it all sort of like hour-long visits, or do you have some control in, oh, this person needs a little less time today, or how does it work?
Yeah, every single patient is an hour. It's when at my last job it was on the half hour outside of an eval, so every session was a half hour, and I always felt like, especially for the ACLs, I was always like, I want to do more, I want to do more, but
Hmm.
I had to pass them off to a tech. But I'm sure we'll get into, I think that exercise is one of the most important things throughout ACL rehab, and a tech is sort of they're not really trained to see these things, and I just think that exercise has to be done under the supervision of someone who really understands it. So that's why I really value this hour-long session. And even with the hour-long session, sometimes I'm like, wow, the hour went by really, really fast, and I wish we could do even more. But you sort of just, save it for the next session. Or sometimes we'll tell the athlete to, stay after for 10 minutes and finish up your block and things like that. But yeah, I really value the hour sessions that we have here.
Yeah, I totally agree. My first job out of PT school was a similar situation where it was an hour eval, and then every follow-up was 30 minutes. And you just always felt like, gosh, there was so much more you could do. You just felt like you were getting done kind of checking in with them and catching up by the time the 30 minutes ended. So I agree with you. And I think for your own mental health as a practitioner, being able to have that extra time, you just don't feel so burnt out at the end of the day when you get an hour with someone. So what now you tore your ACL twice. What sport? How did that happen?
I'm a wannabe basketball player, so that's ultimately how I tore it. First one, I went in for a layup. A guy tried to block me from behind, took me out of midair, and then just affected my landing. So all my weight came down to like I didn't have the classic pop, but I knew something was wrong. Like I couldn't straighten out my leg. The worst part was I didn't have health insurance at the time,
Oh,
so I was unable to get an MRI. I actually ended up paying for an MRI out of pocket,
wow.
and then I had to wait several months to get surgery. So it was a long process.
Yeah. And was your the tear was on the same side again? The
The
second tear?
on the other side,
Oh, on the other
and again,
side.
I'm sure we'll dive into this, but I was never tested properly.
Got it.
Again, think research was probably a little bit worse 10 some years ago when I tore my ACL. So I don't necessarily fault my therapist necessarily, but knowing what I know
You weren't.
now, I definitely wasn't prepared to play. I was cleared at 7.5 months to play in a basketball tournament. So you tell a 22-year-old to play in a basketball tournament, they're going to do it.
Yeah.
So I ended up tweaking it in that tournament, pulled myself out, went back to rehab for about 3 more months, and then about a year or so later, I ended up tearing the other one.
Got it. Yeah. Yeah. That's definitely something I want to touch on. You get into is kind of like readiness for return to sport. 'Cause I know a lot of that stuff has changed, but just thinking about kind of from the beginning of this injury, what would you say are, some of the primary risk factors that come into an ACL injury? I know over the years you hear about different biomechanical, anatomical. Like, what would you say are some of the risk factors that you think about most today in terms of kind of where the research is at?
Yeah, I think that this is a loaded question. I think a lot of people ask me, like, are certain demographics more likely? I know there's sort of mixed opinions on whether females are more likely than males. Like, I see mostly female level athletes, and I don't know if it's just a coincidence or it's because of our facility, but I do think females tend to be a little bit more likely. Some of it, I feel like males are typically a little bit stronger. Naturally, so posterior chain wise, if you lack hamstring strength and you never exercise or actually work out your glutes and your hamstrings, that's going to affect your overall ability to control a deceleration, which we understand is typically the most likely injury factor, right? Is a non-contact deceleration where you're trying to slow down, cut, change direction. That's typically how it happens. Obviously, the contact ones, some of them you can't prevent. Like it happens. But even the non-contact ones happens to pro level athletes. Obviously, like Saquon Barkley tore his ACL, but then you get the contact ones, like Carson Wentz a few years ago was tackled and the helmet I think went right into his knee. Like you can't really do anything about that. I don't care how strong you are, it's probably going to happen. So I do think that plays a role. I know some people look at the Q angle because naturally women are made for birthing, so their hips are a little bit wider, Q angles, knees are a little bit more into that valgus a little bit. So those are probably the two major factors. I do think there's other factors that people don't talk about sometimes, which is I think sleep is really important. Nowadays, like some of these kids come in, they're like, oh, I slept for 5.5 hours. And then on top of that, they're choosing to specialize in sport really early. And so I do think there's a combination of a lot of things that goes into what increases the likelihood of an injury, let alone specifically an ACL tear. I think like I want to say, like for back in our day, I don't think people specialized as quickly as these kids are nowadays. Like sometimes these eighth graders and ninth graders are like, I'm going to play soccer, lacrosse, and that's all they do year round. And then these high school kids go to high school practice and then they might wolf down like a quick meal and then go right into a club practice right after that. Like again, like is a 14, 15-year-old kid's body designed to handle 4 to 4.5 hours of practice, go home, do your homework on 6 hours of sleep, recycle, repeat, and do it all over again? Like I'm going to say that your injury risk is higher also. So I do think that it's there's a lot of factors that goes into sort of which patients are more likely to suffer an ACL tear.
Yeah, yeah, it seems so multifactorial, and I love that you mentioned I remember seeing some of the studies on sleep deprivation and musculoskeletal injury risk. So it seems like I'm talking about sleep so often with patients. Most of the people I'm seeing have pain, just pain disorders and things. So, but gosh, such an important part of just the overall healing process and recovery, and the part you mentioned about so many of these kids. I've got two daughters who are 10 and 13, and there's so much pressure on these kids now, like you say, of just specializing early and putting so many hours into their sport. And you just have to feel like fatigue can be an issue and injuries. And, so we've definitely been kind of careful of trying to expose our girls to different types of sports and movements and to kind of develop their movement capacity rather than, but there is this pressure to like, really be good at one thing. And so it's a tricky thing to align to walk. I remember when I was telling you before we got on, when I was maybe a couple years, I guess I was a few years out of PT school, I went down to USC and did Chris Powers. He had this kind of movement. it was called functional lower quarter biomechanics, and he's such a heavy patellofemoral and kind of knee researcher. But I remember back then we used a lot of motion analysis technology to look at people's biomechanics specifically on those deceleration tasks, like you were talking about. Like it would be a triple hop or a drop jump or you know, things like that, like a land and kind of plant type of maneuver. And we would look at kind of dynamic valgus and how willing they were to kind of like move through knee flexion and kind of like land softly. Like how good were they at that? It sounds like a lot of that stuff are still things you would look at today.
Yeah, I think that control is a really big thing, like neuromuscular control. Sometimes I get these D1 athletes that come in the door and I just do like a simple bound to stick and they're sort of wobbling all over the place. And I'm just like, like it for me, it's sort of logical. I'm a very, I guess I'm a pretty logical person. Like I don't get into the nitty gritty of a lot of things, but I think that naturally speaking, people are like, oh, how do I reduce the chance of injury? And I think two big controllable factors outside of additional to sleep is that the stronger you are, and the more you can control your body, that logically makes sense to me that you will probably decrease the risk of an injury. Again, there's so many other factors like rest ratio and all that kind of stuff that make a difference too. But I think that those are two big things that I really look into. And additionally, those are two big things that I do in ACL rehab, right? The stronger I can get you, and obviously symmetry is going to be important, but also the better I can help you regain control of that ACL side and also work on the non-ACL side, that's also going to help you. And even some of my kids, like after I finish working with them, like when they graduate from physical therapy, I encourage them like, hey, stay in the gym. Make sure you still work on your bounds and your single leg landings. And, one of my girls who graduated 3 years ago, she texted me a little while ago and she was like, I still do my bounds for sticks before my lacrosse games and before my lacrosse practices. And I'm like, that's awesome. Can I say for certain that this is why she hasn't suffered another injury? No. But do I feel like it helps? And I do believe that, practicing that does help you stay healthier.
Yeah, it makes so much sense. I think I've always felt the same way that you have the ability to generate force and how strong you are, but then you also have kind of the movement quality and the neuromuscular control aspect, and it just makes sense. Like you can see where even that kind of bound and stick, where that could almost be sort of like a neuromuscular warm up, and it kind of just gets the system warmed up and ready to control force being put on the system. And it seems like whatever mechanism that's working through. I know for me growing up in gymnastics and martial arts, I did a ton of jumping and landing. And it just, I didn't realize at the time how important it was to kind of my overall health throughout the rest of my life. But I think kind of learning those sports are so good in terms of motor control. You're barefoot and you're on one leg and balancing and landing. And it really has helped me, I think, to, in a lot of ways, kind of reduce the risk of injury and other things I've done later in life. So they logically, I agree with you. They make a lot of sense to me. Like be strong and then also just have good control over your limb. Like it just makes a lot of sense. We can get into the weeds of these really other complex things, but it seems like that's a good place to start in a lot of ways. So that actually was helpful because I was going to ask you, 100% preventing an injury we know isn't possible, especially if you have a contact in ACL. But when you think about those non-contact situations, it seems like you kind of answered the question already, but if you were trying to really reduce your risk of an ACL injury, it seems like it'd be the things you just said: be in the gym, work on strength, and then also work on kind of your neuromuscular control. Are there certain kind of strengthening exercises you would say are kind of go-to ones for maybe kind of reducing the risk of injury?
Yeah, again, I'm pretty, I guess, I want to say black and white, but there's four major groups that I really work on. Obviously, quads, hamstrings, glutes, and glute max and glute med will be included, and obviously your calf. Those are probably the four major groups, pretty much the entire lower limb. And again, the stronger you are, the better off you'll be. The more stress that your body can handle is what I typically will explain to these athletes, because a lot of these times, like the college season or even high school seasons, they're very long. And we had just talked about how some of these high school kids are double dipping, right? They have two-a-days practices and they're 14, 15 years old. It's a tough recipe and it's hard for their bodies to handle that much stress. But if you're just a little bit stronger, that can help you to sort of reduce the chances of injuries. In addition to like neuromuscular control, just working on like multiple angles of single leg landing and different planes of motion, which I feel like is super important. And we understand there's three planes of motion. So working on single leg landing in all three planes, I think is really important to address as well. And I would say working on deceleration over and over and over again can really help as well. So I've been fortunate enough to learn from our strength coaches here of just like sort of different exercises that can be incorporated into like reactive deceleration. So a really basic one would be, when I drop the ball, you accelerate, catch the ball, and as soon as you catch the ball, decelerate. And even within the deceleration, we can change your foot position in multiple ways. I might have you decelerate even footed. I might have you intentionally stagger and put your left foot forward and then or flip it and right foot forward. And I might have you stop and then turn into sort of like a hockey stop, right? Where you turn and twist a little bit just to make them work on decelerating a bunch of different angles. Again, in a controlled environment, but you're doing this over and over and over again, so your body gets essentially more reps into deceleration. So I think if you can combine those three things sort of fairly regularly, especially in season, or obviously preparing yourself off season, but also during the season as well, I think that's a nice recipe for decreasing the chances of an injury. Again, in addition to getting as much sleep as you possibly can, because I think what's recommended for these high school kids is 8 hours, at least 7.5, 8 hours. But a lot of these kids come in the door, they're getting 5.5, 6 hours. They're coming in exhausted. And again, so you just like do that over and over and over again. Like that's just not a great recipe for trying to stay healthy.
Yeah, for sure. I know when I get just an hour less of my normal sleep, I feel like I'm, just cognitively not at 100%. It feels like I feel like my motor control has dropped when I have not had a lot of sleep. You just feel like you're uncoordinated to some degree. Those different drills, those kind of reactive drills you're talking about, will you cue people to think about, is it just kind of like, is more of the focus on just like getting the reps and experiencing those different planes of motions and different strategies, or will you cue people to like, okay, try to bend your knee more when you decelerate, or like don't let your knee move medially and collapse into valgus? Like, are you giving biomechanical cues like that?
So we'll definitely work on that prior to doing something reactive like that. So we'll break it down into more like we basically call it a controlled environment first. So I might give them exactly how far they're going, exactly how fast they're going, and get a lot of reps there. Especially for my ACL, it's like we'll do that for 2, 3 weeks, and then I'll add on like one variable. Maybe I'll have them
Mhm.
go faster, or maybe I'll add in a reactive start component to it, or something like that. There's a lot of different ways to sort of progress exercises, but again, for us, we're very big on making sure it's a proper progression. And again, even within the word proper, there can be 3 or 4 branches that you can sort of go off into. But for us, as far as the queuing goes, like once they're at the point of doing reactive, I typically am not queuing too much more unless I see something that I really feel like needs to be changed. Sort of where something I've learned again from the strength coaches is like sometimes you have to let an athlete be an athlete. And what that means is like you have to let them figure it out, because when you're in a game, we're not there to be like, hey, do this or do that. Like, make sure your knees don't go whatever this way, or make sure you drop your hips a little bit more. Like, we're not there to do that. And again, we also understand that like a little bit of valgus is not inherently bad. It's just whether or not you can control the valgus is the biggest thing, and whether or not it goes into obviously excessive, which is going to be when you're more at risk. So it's sort of a fine line between like, the whole like knee bolus stuff of not making sure that they're so cognitive of like, oh no, if my knee goes inward, my knee's going to explode and I'm going to tear my ACL. Like, we know that's not the reality. Like there's been so many clips on, like I think there was one a little while ago about Kansas State basketball players doing like a hurdle jump, and you see a bunch of the guys like their knees are going inward. Clearly, these guys are playing Division I basketball at one of the top programs in the country, and they're perfectly fine. And even like when you go for a layup or a change of direction, like your knees are going to go into a little bit of valgus. So it's just, can you control that? And that comes back to a little bit earlier when I say glute strength, and I specifically stated glute med strength. I think that a lot of people lack glute med strength and don't isolate it enough. I think people do hip thrusts and bridges for their glute max, but they don't target the glute med enough. But we understand that glute med controls that knee valgus. So that's what I mean by, again, tying it all together to make sure that you have the strength, but you can also sort of use it and functionally use it from the like a deceleration component. And again, that's where sort of all three things tie in together.
Yeah, I love that. There was a period of 3 years where I co-owned a clinical biomechanics clinic here in town in Santa Barbara, and I always would think about this. We had force plate and motion analysis cameras and EMG, and we'd have athletes come in and regular people, and we'd kind of had this like testing kind of battery we'd go through. And I always thought about the same thing that, when you have an athlete, yeah, you can work on some of these biomechanical cues when they're in there, but at the same time, you do have to let them be an athlete and figure things out on their own because, like you said, it's sort of an artificial environment, and you can't expect that they're going to perfectly land and do all these things that you're having them practice in the clinic. There's got to be some room for letting them kind of be that athlete and figure out. how they integrate that into play and into their sport. So that's so, while we're kind of on this topic of kind of thinking about treatment for an ACL injury, could you kind of break down just generally what would the phases look like from right after surgery or right after injury? Kind of what are there kind of big categories you'd think about as you move through?
Yeah, I typically break it down to five major phases. Again, the um, almost every single Instagram I post, like people are always like, when I write a mid phase, everyone, without a doubt, people be like, "What week is this? What week with this?" And I'm like, "I can't tell you because I don't know."
Depends on the
Because
person, like on how they're
exactly,
recovering. Yeah, yeah,
100%. Because like if you and I went through ACL rehab at the same time, like you might be able to do something at week 16 that I can't do until week 22. That means
got it.
that you technically hit your mid phase a little bit earlier than I did. So I really never give timelines. Even for people when I see them, I'm like, I'm not clearing you until 9 months minimum. And like the really, really quote unquote fast ones that we have are right around 9.5, 10 months or so. But we've also had ones that we don't clear until 14, 15 months, like,
Gotcha.
and within that spectrum, did I do something differently as a clinician? Probably not. But was it because some people just took a little bit longer to get through each phase? And that's probably the reality of it. And that's how I believe ACL rehab should be. A lot of protocols out there are extremely outdated and they're very time oriented. And they'll say, "Hey, Tom, at 7 months, you should be back playing, basketball, soccer, or whatever it is." But like, how can you base it off of just purely time? I feel like that's just
For sure.
a terrible variable to look at. And my imperfect analogy is always like, just because you turn 16 doesn't mean you get a license, right? You have to
Yeah,
prove that you're safe enough to be on the roads to drive. And that's sort of how I treat it, is like, you need to pass all my tests in order to be cleared to play. So with that said, as far as the five phases go, generally speaking, the first phase is early phase. That's super basic, right? Full range of motion, get the swelling down, get the quads fired up, and normalize your gait. Those are sort of the 4 to 5 big factors that I look for. I will not progress you to that next phase until you demonstrate that you have, especially your extension. Like, make sure you have full extension. If you're missing 5 degrees of flexion, like, yeah, we'll slowly work on that into the early to mid phase. But I won't really progress. I can't really progress you into the next phase until you show me that you have full extension and your quads are coming back and your swelling is not super big or anything like that. Like, these are the big things that I make sure I address in that early phase. And I tell them, like, we can't. I tell every person, like, you have to earn the right to get off the table. Like, we're spending the majority of the early sessions on the table. I cannot progress you off the table until you show me, again, all those foundational components are there. And then the early mid phase, that's sort of when you're starting to load the knee a little bit more. We're using a lot of BFR. We're starting to desensitize that knee, especially for your ACL patients. Obviously, like, having your quad being loaded with a positive shin angle or knees over toes is very hard. So we have to gradually expose them to that. And that's pretty much what that early to mid phase is, right? You're working on, obviously, still proprioceptive work, single leg balance, things like that. You can start making it a little bit more fun. But that's what that early to mid phase is. You're just loading with a lot of volume because you're trying to regain some of that size back. Because we know, obviously, muscle atrophy is a really big component that's there and prevalent. Like, you notice that their quad is just shriveled up, your calf is shriveled up. So we have to make sure we get all that back. And I
are
would
you
say,
doing a lot of like open chain kind of quad, like quad isometrics in that phase? Would you do some of those? I see different people talking about those kind of exercises where it's like at maybe 60 degrees and it's an isometric there.
yeah, absolutely. I think that
Mm.
there's a lot of research that says that it's perfectly safe.
Uh,
But I think that, with that said, that doesn't mean you're reckless and you just throw them on a knee extension machine and just go crazy with it just because the research says that it's quote unquote safe. There's
mm.
still a thought process that should go about, doing that. Like, I'll start with like a very small tower roll, what's technically considered a shorter quad, but it's almost more of a quad set where you're just working on the heel pop. And I
Yep.
might I might progress that to like a half foam roller and then make sure we do that for a week or so. And then, okay, cool, that looks great. Then we might progress to the full foam roller for the shorter quad, right? You went from a small height to a medium height to a big height. And then with a longer quad or a seated knee extension, I might just have them do isos at 60 and 90 degrees first. Can you tolerate that really well? That's great. Then can you tolerate some light manual resistance from like 90 to 45 or 90 to 60? And then you do that. Okay, cool. That feels great. Then we start going full range of motion. And I usually start with an ankle weight first, just because, with an ankle weight, there's really no resistance from that first like 90 to 60 degrees. You don't really get that until 60 to,
Mhm.
to zero to neutral. And then once we do that for, whatever, a couple weeks or so, I might progress them to we have like sort of 3 different levels of knee extensions. I might go to the easier one first, which is on our cable system. And I can grade that really, really easily. I can make it super light where it's almost like you're just doing your leg. do that, and then slowly work up to our really aggressive knee extension machine, which is our wheel, our flywheel leg X that we use. But I don't use that until they're probably 4 or 5 months post op because it's really aggressive on the pullback. But that's my general rules as far as open chain goes, and it is something that I start relatively early because you have to isolate the quads. We know that the quads are probably the most important muscle, that we have to work on. And if you're not isolating it and only trying to work on it in closed chain, you're probably not doing enough to target the quads, because we know that ACL patients want to offload the quads in any way they can. So the only way to really truly isolate it is with open chain exercises.
Yeah. If you do a squat or something, you could shift your weight,
Absolutely.
you can use your glutes. It's like you can compensate all around.
Absolutely.
Yeah. So that's early mid phase. That's the second.
Yep. And that's
Okay.
also the phase that I think is really important as far as teaching goes. Like, this is when we're making sure you're like the foundational, whatever, 8 to 10 exercises that I use, they are really, really good at those, because in the mid phase is when we start to progress it, right? We're starting
Mm,
to maybe slow down the tempo, or we're trying to progress height or progress weight. Like, that's sort of that mid phase when you're trying to basically dose things up a little bit more. That's also when we're starting to get you closer to jogging. Like, right before that early mid to mid phase is when you're starting to work on like single leg landing and working on deceleration a little bit. Make sure that knee can, obviously at this point, hopefully that knee is comfortable being loaded in a positive shin angle. So doing like a forward step down, you should be comfortable doing that at this point. But you should also be comfortable like stepping and loading into that knee. Because if you can't do those two things well, if you can't step and load into that knee, and you're not strong enough, jogging is out of the question, right? You
hmm
can't, physically cannot do that without those two major components.
Yeah.
So that's sort of that phase of trying to work on that. But again, we're also trying to start to continue to really build strength now. So again, all those progressions that I talked about is that mid phase. And this is the phase also, again, when jogging starts to look really good in that like later mid phase and entering that mid to late phase, movement is starting to become a big part of the process, right? These sessions are now, instead of being sort of hour long of mostly lifting, we're starting to do maybe 15, 20 minutes of movement, trying to get you, moving comfortably laterally. And we talked about deceleration earlier, working on deceleration components. Um, that's sort of this like mid to late phase, or early mid to late phase, whatever you want to call it. And then eventually progressing to obviously a reactive component. And then that's when you're starting to enter that late phase of rehab, when we're really starting to move again, starting to feel like an athlete again. But again, the component that's always there no matter what, and I don't care if you're 2 weeks post-op or 45 weeks post-op, is strength always has to be a part of the session.
Yeah.
And that's, I think, a part of the athlete understanding that. And that's why, again, in that early mid phase of understanding, like, do you know how to do a split squat? And do you understand that this progresses to a Bulgarian split squat? And do you understand that a forward step down is a really good quad isolating exercise? Like all those exercises that you're doing at 9, 10 weeks, you're probably still doing at 40 weeks. It's obviously just a significantly progressed version, whether it's heavier weight, more depth, decreased tempo, whatever it may be. But that's sort of how I like to rehab. Like I think a lot of people see the Instagrammy stuff, and like, sure, I'll post some of the stuff that's more exciting. But at the end of the day, like, we're the foundational lifts are still there, even if you're really, really late phase. And then, when that late phase, we obviously are testing pretty frequently, maybe 3 weeks or so, 2 or 3 weeks, and just tracking numbers. And as soon as you sort of hit that, for me, when you're right around 85%, that's when you're starting to go back to practices, non-contact practices, maybe light contact. And then right when you're 90, ideally close to 95% symmetry, I'm starting to start releasing you back to play. But even within back to play, like, there should be a minutes restriction. I think that's really, I'm really, really big on that. I do something like 50% of your games, of your usual minutes for about 3 games, 75% of your usual minutes for about 3 games, and then you can start gradually working in full games.
Yeah.
And like little things we've talked about a lot of stress management. If you're a star player and it's your fifth or sixth game in, or you're in your eighth game in, right? You're back to being your full minutes again, and you're just destroying this team. It's like soccer game 5-1. Just pull yourself out. There's no need to
Yeah.
expose yourself to excess stress. Because I think the kids who are jump into things too early, they go back to those two a day practices plus games, 3 games a week. Then they start developing like shin splints, or like, oh, my quad strain. Like, that's the other factor that I think people don't talk about enough. Like, yes, you are safe to play, but now you have this like nagging fill in the blank that you're dealing with because you expose your body to too much too fast.
hmm
And I think that happens a lot with, I would say, my college athletes, because like it's hard, and I get there's a lot of politics with it, that you're fighting for playing time and you're competing with every other girl who's been healthy for the past year. So I get that side of it, but at the same time, like, the whole saying goes like the best availability, the best ability is availability. So if you're not
Totally.
available, then that makes it a lot harder for you to even gain minutes. So it's always a wrestling match when you're clearing kids to go back to sports again. But I think that I'm really, really big on having a gradual exposure back to sports again.
Yeah. Yeah, I love it. I just love from the beginning that this isn't based on time frame because that's how it always was. Like when it's like all the surgical protocols, it was always just like a certain number of weeks and it just doesn't make sense. It should be based on the person's abilities and their strength and their control. And I love that you almost everything's a test. It's like you have to pass these things before you go to this next level, this next phase. And there's all these, every exercise is a test in a way. It's like, how do you move with it? How strong are you? And just the fact that I agree with you, so much of what I post on my social media are the same exercises over and over again. Like the basic exercises, like, yeah, they're not always that sexy, but they work. That's why we keep using them. So I like that. I think I saw on one of your links on your website that you had a thing where people could sign up to get like the 12 exercises that are kind of the ones that you guys commonly use
For post-op, yeah,
um,
the immediate post-op
for
exercise,
post op.
and
Yeah.
they're boring. They're not
Mhm.
exciting, but what does it help you do? It helps you regain your motion, right? It helps you get your quads firing again. It teaches you even how to elevate, like simple things like that. And I don't want to call them simple because they're mandatory. You have to do these
Mhm.
things. If you don't do these things, if your knee never gets fully straight, you're gonna have a really hard time jogging again without pain.
Yeah.
That's again that's why I'm really big on educating patients on, like, we're doing this because I need your knee to be fully straight in order for you to walk. You can't If you can't walk, you can't jog. Like, it's very, again,
Mhm.
relatively basic. So that's why I think educating patients on, like, your why is so important. So they're not just being like,
Mhm.
oh, he's sort of being like buzzkill and he doesn't want me to progress and all that kind of stuff. Like, no, you need to have your full range of motion back. You need to be able to do a straight leg raise without a quad leg. Like, all these, again, fundamental things you have to be able to handle before you go to that next phase.
Yeah, yeah, the why behind things is just so huge. I mean, otherwise, patients do just feel like you're just randomly throwing stuff at them and, just making them do these boring exercises. And it's like when you actually explain why they're necessary from a biomechanical standpoint, you need this thing to get to this functional task. It's like you need knee extension just to put your foot out to heel strike when you walk. And, the average person doesn't understand like where the knee comes into the gait cycle and just all these things. I think, obviously it's such a huge part when you mentioned the symmetry and strength, and I remember seeing those studies. It was like if it was more than a 20% asymmetry, is it something like that, it was 80% or lower, the risk of injury, like it goes up dramatically, right, if have
Yeah,
that
what research
asymmetry and
support
strength.
is anything under 90%. Um, excuse me. There's one article that said, specifically, I think for every percentage point you're under 90, you're 3% more likely to suffer a re-tear. That's probably the one you're referring to.
That's what I'm thinking. I was 90%. Yeah, yeah,
Yeah,
yeah.
and it's nice to have all this data because, like, at the end of the day, like, this is, I always tell patients, like, this is, and parents, this is what I'm using to dictate, like, when you are safe to go back. Like, yes, I might keep you for a month or two longer, but I'm not keeping you for the sake of just keeping you. I'm Here are your test numbers, right? This test says that you're at 83%, and there's research out there that says, a lot of research says being above 90 is ideal. And I actually push towards 95 if I can get them there. It's hard because sometimes they've been itching, and I tell them that 90 is the minimum, but the gold standard is closer to 95. And I explain it because, like, we understand in sports, like, when you're in season, you lift less. So if you lift less, you're probably going to be weaker, right, in season. So I tell them that if you're at 90%, you better stay at 90 because, again, research supports that if you start dropping below, you are increasing your likelihood of suffering a second ACL tear. So I tell them that, like, if you go to 95 and you drop 2%, you're still in considered that safe zone. And that's why I want them to be close to 95%. And there was an article I read a while ago. I haven't been able to find it since then, but it basically looked at, like, the strength deficits, or the decrease in strength that athletes go through during a soccer season. And it's just, these are the things that we need to be aware of. And I tell them that after you're done rehabbing, right, you've been cleared, you're back to practices, you're back playing games again, you better still be lifting in season. Do you need to go as heavy as you were when we were in the late phase of rehab? Absolutely not, right? Not in season, but, like, grab a 15-pound dumbbell, something light to moderate, right? And go through, like, single leg box squats and heel touches and some sort of split squats, like something basic. Even if you just do it for like 6 sets, it's better than 0 sets.
Mm-hmm.
And that those are sort of, and working on your neuromuscular control. I think doing these, again, quote unquote, little things can really help to um, decrease the chance of a second ACL tear, which is ultimately what it's all about. And then sometimes we'll get kids that come back after 6 months and get retested. And that's obviously, I think, a really big important factor too, is like if you come back, get retested, oh, your quads dropped by 2 percentage points, or your hamstrings are now uneven or not even strength, right? Okay, cool. Make sure that either you do yourself or go back with your strength coach and maybe you isolate a little bit more hamstring work to even it out again. I think these little things can go a long way as helping an athlete stay healthy.
Yeah, the objective data is huge. It's just so nice to have that. When you guys are testing strength, is it on like we used to use a big biodex dynamometer? What do you guys use to measure strength?
Yeah, so unfortunately, we don't have a Biodex. I wish we
Yeah,
did. It's obviously still considered the gold standard, but that thing is extremely expensive and large. um,
Totally.
so we do isometric testing first. That's probably the number or easiest way to do it first. So we do isometric for quads and your hamstrings. But I would say the biggest equipment that we have here is called the LegX. It's by Go Eccentrics, and it's basically the flywheel system of a knee extension
Hmm.
that they invented. The cool thing about it is that you are able to connect it to an app, and the app basically spits out your data. And
Got
it
it.
tells you we do it for 5 reps, and it basically tells you your concentric average between the 5 reps. And it's so easy for me to compare your non ACL side to your ACL side. And I tell my athletes, like, if for whatever reason I only was able to pass you on one single test, it would be based on that. And I've had multiple athletes who have access to a Biodex at their colleges who have done my test and they've done the Biodex, and they tell me that it feels extremely similar, which for
Hmm.
me is awesome because that tells me that like our testing is very robust and very, very challenging.
Yeah.
And a lot of times, like, and I think this is probably one of the biggest things that are missed in ACL rehab is that people don't have the ability to test isokinetically. So like for us, we have the isometric is great, and literally just probably 2 weeks ago, I tested one of my athletes. She tested at like 97, 98% isometrically. So that's awesome, right? That's a really big number to be a part of. But I put her on the flywheel system, and she was testing at like 84, 85%. So
Hmm.
for her that's a really big difference, right? 12,
Hmm.
13%. Like one test says you are safe, the other test says you are not safe. In my opinion, you are not safe to go back to play yet. She's practicing, which is great, even doing light contact, but we need to get you at above 90 before we clear you to play in a game.
Hmm.
And I think these are the little nuances that go missed sometimes. I think isometric is great. It's super important. It's a great place to start. But I think having the ability to at least test like concentrically is super super important. Even if it's like a 3 or 5 RM on a knee extension machine, I
Yeah.
still feel like it gives you enough data or enough information. And I think that like if you're going heavy enough and you're really finding their true 3 or 5 RM,
Yeah.
if there's a difference, it'll expose them in that environment. But thankfully, we
Y-
have the leg X to do that.
Yeah. When you guys are doing isometric, is it with a handheld dynamometer or is it? It is.
Yeah, with the handheld.
Got it. Okay. Yeah. So you said when you're thinking about kind of returning to practice and playing things, that quad strength is, do you say that's one of probably the most important factor to you? Yeah.
Yeah, usually
AC.
around like roughly 80% when they're testing, I start to try and find to see if they can find like a skills coach to work with. So like we have great relationship with like some local soccer coaches. They do like individualized training, which is really nice because that's a very controlled environment, right? So if you're testing at 80%, that means that you obviously are not cleared to play in a game yet, but you can still get into a pretty like intense soccer training session, right? Just don't go like 100% full speed blasting, getting hit, change of direction, that kind of stuff. But like, can you sprint? Absolutely, right? You can sprint. Can you change direction? Yes, absolutely. You just have to make sure that you're doing it in a more controlled environment and maybe at slower speeds. But that's when the rust is starting to shake off a little bit. And as far as their sports goes, like, and that's when athletes really start to get motivated. Like, okay, wow, like I'm starting to feel like an athlete again. Like
Mm.
my touch is coming back, or this feels rusty, and I need to work on this. And that's sort of that fun phase when they're really getting to that final phase of like we're getting really close. That light, you can see the light now. But that's usually my general rule is like I would prefer them working with the individual skills coach first. It's just so much easier, even mentally, of like, oh, it's just me and a coach. Like there's no pressure here to
Yeah.
perform in front of my actual soccer coach or my peers. Like they don't need to see me being rusty right here. I can work on that rust right now for who knows 3 4 weeks or so. Cool. After that, now you're testing 85%. Let's introduce you back to practices again,
Hmm.
And then at that point, you had already done hopefully 6, 7, 8 sessions of like individualized skill work. Your touch is better now. You can give off like a better presentation to your coaches, and you're stronger than where you were a month ago. And that's sort of the general rules that I like to follow. And then again, when you hit 90, we're starting to think about really setting you free and getting you back into sports again.
I love that the idea of a skills coach because you do hear about the psychological readiness side of things and the fear of re-injury, and you see that with patients. And geez, that pressure of like your coach, like you say, and your peers on the team, like that's those are big factors to consider. And to have someone who's kind of like an independent person where you don't have to worry about them as much, and you can kind of get the rust off and get through some of the fear and some of those psychological variables. That's such a great idea.
Yeah, definitely. And
Uh,
we also have a great relationship with our one of our owners. Like me and him do, and he does it with all the other PTs also. But like we'll basically co-treat at the very end. So once they're roughly, I know it's a hate timelines, but once they're in that like mid to late stage,
hmm
I'll start introducing him into the equation. And essentially, he's responsible for doing movement. You had talked about like movement mechanics and working on like cutting angles and all that kind of stuff. I let him do that because that's what he's an expert at. And I'll do the intro stuff. Like I will work on deceleration at early phase, but I also understand that within my scope, like that's not my job is not necessarily make you faster. My job is to
hmm
make sure you are safe to go back to playing sports again. I'm still dictating sort of what they can do. So I'll tell like, hey Matt, like, she's testing at 80%. She can start moving again, but I will maybe stay away from like a full speed change of direction exercise. And he'd be like, got it. And like we'll obviously like stay in communication. It's nice because I can literally walk over to him and tell him. But that's again when it's really really fun because then you're working in me. You're also working in the strength coach side of working in like reactive movement and like working on power and explosiveness, which we understand also is super important. Speed, acceleration, change direction, quickness, like all that stuff is what he does. And then you also throw in the last component, which is a skills coach for your sport. That's when it gets really fun. Of like now we're really starting to feel like an athlete again. And it's we understand that not everybody has these resources. But with that said, like I think that within our area, it's a really nice sort of triage to have in order to get you back to playing sports again. Just like you said, addressing the psychological side, getting a ton of reps in a very controlled environment. And then sometimes Matt will take two ACL kids and put them together, right? Who are roughly in the same phase. Now we're going to compete against each other. Both of you are going to stay within whatever 80% speed, but you're going to compete against each other. Now you're adding in like a reactive component. Now we're really starting to feel like an athlete again. So it's just nice to have like a progression of things that we can do here, and again have resources with all these coaches that will really help with that late stage process. Like again, my job is not make you a better soccer player, basketball player, whatever it is. Like you don't want me doing that. My job is to make sure okay, you are safe to do fill in the blank, and then communicate with the coaches directly. And then maybe if their legs are beaten up, I might be like, okay, maybe we should cut back. Like let's skip the soccer session today. Because at the end of the day, coming back to what I said earlier, strength is always the number one priority. That has
hmm
to be the priority. All the other stuff is great. Like I want them to be able to do that. But if you if you have a spike in volume, or we talk about rest, like let's say the kids like they had 4 exams one weekend, they didn't sleep that much, and now their legs are beaten up. Like maybe you should skip your skills coach that day or skip
hmm
that week. Like there's all these things that you have to adjust and all these variables that you have to accommodate for. But again, always focusing on the end goal, which is ultimately getting back to sports safely, is always the end goal.
Yeah, I love all the steps and progressions, and like you say, bringing in someone like you've got you, who's the rehab, like really making sure they're safe and they can, perform things with correct sort of biomechanics, and they've got the strength and the motor control, and then you've got like someone who's like kind of maybe more a little more on the performance side and working on like speed and explosiveness, and then you got the skills coach. I mean, I think that's a really cool concept. I know, we were talking about there's not really time frames here because it's based on that individual person and kind of how they're moving through things. But the one time frame it does seem like that comes up, and I know you've alluded to it, is like no, not returning to sport earlier than 9 months because of the graft just hasn't had time to heal. Is that true?
It's that is part of it. I know there's mixed data
Hmm.
as to when the graph becomes fully like integrated, but I would say the 9 months is mostly just due to strength. I think
Oh,
that
okay.
it's really hard. I maybe have seen it a couple times where people to be symmetrical before 9 months. And the 9 months at the end of the day, I think is sort of an obscure timeline. It's just I think what research has supported is the minimum. So that's sort of what I tell. And there's a lot of research that says 9 months is the bare minimum. But at the end
Mm,
of the day, it's not necessarily the time component. It's just the fact that that extra quote unquote time is allowing you, hopefully, to keep rehabbing, right? That's
got
ultimately
it.
what it tells people is that like you need to keep getting stronger in order to again retest. Now you're at 88%. Okay, cool. Let's retest again. And now you're at 92%. Cool. Now we're setting you free and back to sports again. And like for
Hmm.
me, especially for the leg X, because this is the hardest test to pass, and for anyone who has done the biodex, it's an extremely hard test to pass. Like once you pass it and you see that chart is even, like it's just such a amazing moment,
Yeah.
because you know that you're even. Like that's the number one goal is that when I put these people on the test, like even if you're at 84%, you feel a difference when you're 84%. And that's the big thing is like I want these tests to expose their weaknesses, and I tell them that you would rather be exposed in here versus being exposed out on the field again with some reckless slide tackler or whatever it is, and then you get hurt again. That's not where you
Hmm.
want your weaknesses to be exposed. And that's ultimately again why I tell them like we need to test. You have to pass these tests. And we're batting a good percentage as far as our re-tear goes, and I think a lot of that comes down to the fact that like the rigors of how hard we're rehabbing, but also like how hard our return to sport testing process is, because there's a lot of places that don't have any equipment, let alone having isometrics. Like that's obviously a
Hmm.
start, but I think that a lot of places don't lack the equipment to test properly,
Hmm.
which I get is tough. Like biodexes are so hard to come by, like they're really hard
Yeah.
to come by. I wish they were much more readily accessible. But I think that for those facilities who don't have any testing, like I don't fault you for it because if you're not the owner, like you can't control what they buy and things like that. Maybe you recommend it and the person's like brushing it off. But that means that it's the therapist's job to find someone who is able to test properly, and
Hmm.
I think sometimes people in our field don't really do that. They'll just be like, oh, they tested, they look really good, boom, send them off. And then they get hurt again. And I think that
Yeah.
our field, in addition to athletic trainers, both need to do a better job of properly rehabbing and also properly testing because ultimately again that's what research supports will deem when someone is safe to go back
Hmm.
again.
Yeah, it can't just be based on what you think, what you see visually. You've got to like, do your homework and find if you don't have that equipment, refer them somewhere where they can actually get tested. Because yeah, like you say, if you re-tear, I mean, geez, like, you think about how long the process is for all of this. It's like the last thing you want to do is not have that data and go in too early and just re-tear again. So let me ask you, so many people, I see new kind of research looking at the ACL potentially being able to heal without surgery. And you always get people who are kind of sometimes you get people who ask like, hey, do I need to have surgery for this injury? Like you hear about copers versus non-copers. Like, where do you fall on that now?
I think based on the demographic that I typically see, it's a hard sell to tell them to do this. We actually just talked about this in our staff meeting yesterday. It's I forgot the exact name. I think it's like cross bridging or cross bracing, but it's like there's a research article out there that I think looked at like 50 some people that went through this rehab protocol, all had ACL tears, and from what I remember of it, I don't remember the exact details, but basically like the first phase of that protocol is that your knee is in like this cast or brace at 90 degrees, like 24 hours a day for six
Hmm.
weeks. That's a
Wow.
hard sell. You have to shower with this like 90 degrees. You cannot, because the whole goal is that you're trying to allow the two ACL ends to meet in order for them to like sort of cling on to each other and start to heal again. And then from there on, like each week, you start to straighten out that leg a little more, a little more, a little more. And I'm pretty sure from what I remember, it's not until like week 11 or 12 until your knee gets to full extension.
Wow.
Yeah, and like it's how can we get people to buy into that? And even then, I think that the success rate was actually pretty good from that one. But there's obviously like different standards that you have to go through or criteria that you have to meet in order to be a part of that to be considered the right candidate for that. I think it said like full ruptures are not a candidate. Um, and I don't remember some of the other criteria, but like
Hmm.
how am I going to convince a 16-year-old kid who wants to play Division 1 basketball to be like, hey, like you're gonna do this thing and you're gonna be locked out for 6 weeks at 9 degrees, and then you can't even walk normally until you're probably 3.5 months post-op. And on top of that, like not to say this
No
surgeries
guarantees it'll even work, right? No
correct.
guarantees.
And
Yeah.
I do think it's a very cool thing. I think for the right demographic, like if you're like around someone our age and you
Mhm.
have the ability to potentially do that and you maybe work from home and all these there's so many factors that goes into play. Like it's a good option for those people. But again, I think that I would like to see more research on this stuff before I start like really recommending it. But even for my like, even if you don't go that route and you just choose to go strictly non-operative, again, you said it perfectly, copers or non-copers. Like, can you can you get back to doing what you want to do, or are you willing to forfeit giving up something because your ACL is too torn to handle that, you know? And are you willing to put in a lot of work in the gym to get very strong because your muscles have to make up for the lack of ligament stability that you have in your knee? It really just, there's so many factors that goes into deciding like yes or no. And just like you said, there's no guarantee, you know, like it'd
Hmm.
be hard pressed for me to be like, hey, like definitely don't get surgery. And then 6, 7 months later, they try to play basketball again. Their knee buckles, and they come back to me and be like, I just wasted 6, 7 months. Like I could have just got
Yeah.
surgery, and then 6 months into my recovery process, you know. But
Hmm.
again, we also know with surgery, there's no guarantee either, and that's why it's like
Yeah.
it's so hard to tell. I just tell them like, what do you want to get back into? Are you willing to put in the work, and are you okay if this fails? And if the answer is sort of yes, yes, yes to all these things, like okay, let's go try the non-operative route and see if we're willing to like bypass surgery, because surgery is a very big deal. There's complications
Hmm.
that can happen, and all these things. Like even within surgery, there's no guarantee of you getting back again. So yeah, those are sort of the big things. Like I explain to the patient of whether or not like they can go non-operative or need or require surgery.
How many people would you say go the non-operative route that come through? I would imagine pretty small.
Yeah, and I think I've maybe seen three in my career, and
Yeah, totally. Yeah.
they were all adults.
Oh, yeah, yeah,
And I think
yeah.
one was just like a runner, so obviously that's really
Hmm.
safe, right?
Yeah,
You don't really need your ACL to run straight.
yeah.
And I also explained like, there's been pro level athletes who have not had ACLs. You know, I think DeJuan Blair, who played in the NBA for several years, Hines Ward didn't have ACLs, who played in the NFL. Like but again, like their job is to like be as fit as possible, and
Hmm.
the average adult can't, like you and I cannot commit 6 hours of our day to just train and rehab and get really really strong. Like that's not a part of our job. You know, like we're therapists, like we have to work. So that's like it's hard to explain it, like because people always look at the pros, and I'm like, you're not a pro. You know,
Yeah, exactly.
these guys the elite of the elite. They're the 0.0001% of the population that can handle this. And unfortunately, like you are an engineer or you know whatever it may be, like it's hard for you to commit that time to do that.
Yeah.
So yeah, it's always like with everything. Everything is it depends.
Yeah, totally. And that makes sense. Like it's all those factors that go into it. Like you said, if you're somebody if somebody, they're not an elite athlete anymore, they're in their 40s or something, and all they do is run, like, yeah, maybe they can go the non-surgical route. But at the same time, they also aren't the person spending all the time strengthening. They probably got a job where they're likely sitting, and there's so many factors to consider. I was talking to an orthopedic surgeon the other day who, and he was talking about the risk of like early arthritis and other injury to other passive structures within the knee joint if the ACL isn't reconstructed. Just maybe there's some movement between the tibia and femur that you aren't even aware of that is damaging other structures. And so yeah, it's with the patients who are coming in. I remember when I back in the day when I was seeing more ACL patients, if they were an athlete, they'd get a patellar graft. I think maybe they talked about being stronger than the hamstring graft. Is that still the case? Or even a cadaver graft, I guess. What do you see with most people?
Yeah, I actually don't really. I actually can't remember the last time I seen a hamstring graft. It's
Okay.
just and I would say the really cool thing is that it probably depends on location, whether it's in the
Yeah.
States or even overseas. Like I in my course that I taught a while ago, one guy came from Germany, and he says pretty much all he sees is hamstrings. And I was like in shock because we
Hmm.
don't see hamstrings here. But for us, mostly patella and quad grafts. The quad graft is sort of slowly gaining more and more popularity because it's not attached to a growth plate. So if you're 14, 15
Oh.
years old, the quad graft is a better option because your growth plate is still open, so we can't take it from the patella tendon, but you can take it from the quad tendon,
Hmm.
and not sort of decrease that hamstring strength that is obviously super, super important. I
Yeah.
think that the understanding is that every single graft has pros and cons. Just explaining all the pros and cons to the patient and allowing them to help them make a right decision. But a lot of times the surgeon will sort of go over those in rehab as well. But if we see patients for prehab, they'll ask me like, "Hey, what is your graft preference?" And I'll sort of, weigh the pros and cons of every single graft. I would say cadaver is just not one that we see very often. Also, just
Mm.
again based on the demographic that we see, I think if you're like a 45-year-old who's not super active, who maybe tore stepping off a curb or whatever by accident, cadaver is perfectly fine option. But we also know that it has the highest re-tear rate.
Hmm.
So that's why, for us, like we just don't see a lot of hamstrings and quad grafts. Or sorry, hamstring and cadavers here. I've probably seen
Cadaver.
Between both those two grafts, I've seen less than 5 in my 7 years of being a healthy baller.
Yeah, gotcha. Huh. And I didn't even know that there was the quad tendon graft. I hadn't heard of that. I think back when I was seeing it was just all patellar tendons. So that's interesting. Makes sense. It's not attaching to a growth plate, so that's cool.
Yeah, yeah. There's again pros and cons of that graft too, but I would still probably rather choose that over the hamstring graft.
Yeah. Well, thanks, man. I know we're getting right about to the hour point. I want to be respectful of your time. This was just so insightful. But reassuring in a way that even though I haven't been in this world in a while, I feel like I still have some idea of what's going on. So, I really like gosh, what you guys are doing is so amazing. Like just thinking about the different phases, not basing it on time, like where is this individual person at? Just the logical progression and, biomechanics, these simple exercises and movements, and then let's just progress those over time. I think it just all makes sense. You wish everybody had access to kind of what you guys are doing and the length of time you're seeing people, because so many people, right? Insurance runs out. They might have, I think back in the day, most of our patients, unfortunately, the ACL patients were only in the clinic. It seemed like 3 or 4 months, something
Yep.
like that. And then you were like trying to help get them to maybe a cash pay operation somewhere where they could still be in rehab and work with strength and conditioning specialists. And the model you guys have got just sounds like what is needed based on what we know from the research for this injury and surgery and the recovery process. So cool. Thanks for sharing. I know you've got a bunch of resources. I know you'll sometimes see people virtually, and then of course the clinic there. Where can people come find you? Like find resources if they're going through something like this?
Yeah, most of my stuff is on Instagram, just wesleywang.dpt. But yeah, most of my links are on there for anyone who's looking for virtuals, but also any therapist who's looking for more like continued education as far as the ACL rehab world goes. For me, I'm just trying to utilize my platform to improve the knowledge surrounding this very specific injury. I think that it's a very big deal, but the majority of our field, as well as athletic trainers, sort of doesn't fully grasp that yet. And that's sort of what I use my platform for. And I think a lot of people might look at my Instagram and be like, "Why is this guy so crazy about ACLs?" Because at the end of the day, it significantly impacts somebody's life, let alone going through it twice.
Hmm.
Like even with like social anxiety of like, oh, I'm missing my sport, and that team that was recruiting me dropped me, or I'm not getting any playing time because my coach looks at me as damaged goods. Like there's so many things that goes into this process, which is why I'm so passionate about it and making sure we do it the right way the first time. But yeah, that's sort of what I try to use my platform for.
Yeah, I think it makes so much sense. I've sent a ton of people to you over the years because I think it is such a it's such a big injury and it's so specialized that I appreciate that you've really niched down and specialized in it because it's so helpful to have people patients that ask me because I don't even want to see anyone with this anymore because it's just not my specialty area. I'm not treating it on a regular basis. I think if you aren't treating it regularly, you don't understand all the nuance everything that goes into it that you just shouldn't see those patients like send them to someone that this is all they do and so I appreciate that you're using the platform I know there are a lot of times I've looked at it and it's nice to be able to come over and learn a little bit about this topic from your page and then again just to have a resource to be able to send patients because there are so many times I'm like I'm not the best person to answer this for you. You should go talk to Wesley. So thanks for all you do. And I'll share links down in the show notes for people if they want to come check out your resources and sites. But thanks again for being on today, Wesley. I really appreciate it.
Yeah, I appreciate you having me on, Tom.
All right, you guys. See you in the next one. Bye.